I've also been asked to touch on therapeutic approaches, and I fulfill this request with a disclaimer as a non-clinical scientist. So all I share about treatment is from reviews, articles recently published by clinical colleagues, as you will see referenced throughout my slide. But so let's challenge accepted, let's crack on. So today I will be defining what paradoxical psoriasis is for some of you who might have joined us a little bit later and missed the first talk, and then go through all the different flavors of this condition, and then talk about challenges and opportunities. So what is paradoxical psoriasis? It's defined as a worsening of existing psoriasis in patients undergoing treatment with targeted therapies, and you see examples, all the biologics used for psoriasis can give rise to some sort of the other paradoxical reaction, or new onset psoriasiform reactions in patients treated with targeted therapy for different diseases, for example, IBD or rheumatoid arthritis. But I like to consider paradoxical psoriasis nowadays as an umbrella term. As you can see now, there are different angles to it. But where did it start? It started really already in over 20 years ago. And if we now go back to a randomized clinical trial for anti-TNF back then, you already see some safety signal, both in patients treated with etanercept, with some worsening of existing psoriasis, or for patients with spondyloarthritis suddenly developing psoriasis. Of course, those signals were missed back then because they were very small. But already 1 year later, we have the first case reports of paradoxical psoriasis induced by anti-TNF. And you see here the very first one, really, already published in January 2004, and 3 more publications in the same year. 1 year later, more case reports, 2005, 7 more reports were published, and I like to highlight this one, which for the first time used the terminology of paradoxical adverse reaction. So this is just taking you back to the history. But all it started with paradoxical psoriasis induced by anti-TNF or TNF inhibitors, and we now know that affects about 5% of patients treated with anti-TNF. The incidence varies according with different drugs, but is most common with infliximab. There seems to be a female sex preference, and the onset really can vary from 1 month or years of treatment with mean time of 11 months. And you can see here the phenotype can be quite different. There can be plaque or palmoplantar pustular psoriasis, about in half of the patient. That's the phenotype that is observed, but you can also see inverse guttate generalized pustular psoriasis. And what is really typical of paradoxical reaction induced by anti-TNF, they usually resolve with the drug discontinuation. But in up to a third of cases, they might be persistent even when the drug is discontinued. At least that's what the literature reports. Now, you have already heard about the pathogenesis, what we know about the pathogenesis of TNF-induced paradoxical psoriasis, which is really driven by this uncontrolled interferon alpha signaling, which is unleashed by the TNF blockade. Normally, as you can see here, TNF will block the production of interferon alpha in PDCs because it induces their maturation, so the PDCs switch their activity. But this is not happening in the presence of an anti-TNF. And what is really typical of paradoxical psoriasis, and this was shown beautifully by Kurdin a few years ago, is the T-cell independence. So in contrast to classical psoriasis, you do not need T-cells to be involved, because this is all really driven by elevated type 1 interferon. And we heard just early on how maybe this mechanism might be due also in paradoxical psoriasis to the complement. Obviously, Michelle showed us data about persistent psoriasis. My question would be, is this also underlying paradoxical psoriasis? What else do we know about paradoxical psoriasis induced by TNF? So quite annoyingly, we don't know much about the genetics of it, because one thing that the data show is that this is only happening in 5% of the patient. Why? The first problem is there is no published GWAS study done in paradoxical psoriasis induced by anti-TNF. There are some putative associations in the literature with genes such as IL-23 receptor, CTLA-4. However, they should be taken with caution. There's been no replication, and the statistics might be a little bit shaky. So really, we don't know anything about genetic susceptibility. There has been a wealth of research more recently, and for example, we know that IL-36 and IL-22 has been suggested to be elevated in paradoxical psoriasis versus classical psoriasis. But again, we are still at the level of phenotyping and not really understanding what's happening beyond the type 1 interferon signaling. Now, disclaimer, my lab does have an interest in paradoxical psoriasis, so I do have a little reason to be here talking to you. And we, together with our colleagues, clinical colleagues at St. John's, we have assembled a small cohort of paradoxical psoriasis patients, 12, and we have matched them with the healthy controls, but also with patients with psoriasis receiving anti-TNF for 12 weeks and not developing paradoxical psoriasis. So this was our preferred control group. As you can see here, the majority of the patients with paradoxical psoriasis had active disease at time of sampling, but some were historical, so the disease had been already resolved, and the parent disease was either psoriasis, ankylosing spondylitis, or IBD. What we did was deep phenotyping of plasmacytoid dendritic cells, and what we found was that in comparison with healthy volunteers, PDCs of PXP patient had increased frequency of PDCs expressing chemotherapy receptor 23 and CXCR3, both skin-oming markers. However, what was interesting to note that in the case of chemotherapy receptor 23, this was already happening also in patients treated with anti-TNF and also in patients with psoriasis at week 0, which is before the treatment. In contrast, this different expression of CXCR3 was really driven by the anti-TNF treatment. As you can see here, that the levels were actually even higher in patients that do not develop PXP, at least in the first 12 weeks. So really suggesting that there is something going on beyond the immune dysregulation, which might be genetics. And I think we will be discussing, but this is really something that should be looked more closely. Now, what about treatment? So anti-TNF-induced PXP is managed according to clinical severity and the control of the primary disease. So there is a so-called treat-through approach for mild PXP in which the underlying disease is well controlled. In that case, the idea is to use topical steroids plus vitamin D or conventional systemics just to manage the PXP. But then when the PXP is severe, the option is drug switch. And there are different options in patients without IBD, especially with palmoplantar phenotype, anti-IL-17 are preferred. Or in contrast, patients with the mixed psoriasiform eczematous phenotype or with IBD, anti-IL-12-23 or anti-IL-23 are used. And as a second-line treatment nowadays, obviously, there are also JAK1 inhibitors. Now, let's switch to another flavor of paradoxical psoriasis. This is IL-17-induced paradoxical psoriasis. And in the literature, there are about 20 cases of worsening psoriasis or morphological changes of psoriasis with secukinumab, and a handful of isolated reports with other agents. However, very often, they lack histological confirmation, and this will lead to one of the challenges, really, the clinical phenotyping and diagnosis. Now, in most cases, happen in patients with pre-existing psoriasis. However, I like to highlight here this case of bimekizumab-induced PXP in patient treated with HS, which develops scalp psoriasis, but also says in the paper classical plaque psoriasis. Now the presentation again are quite heterogeneous. They include classic plaque type psoriasis, GPP, and palmoplantar pustular. However, there is a clear lack of molecular phenotyping and very little mechanistic insights. It is unclear whether these are true paradoxical exacerbation or is a flare-up of the disease, and whether there is any compensatory mechanism and pathway being activated, for example, in this patient. And in terms of therapeutic intervention, they are equally not standardized. Again, there is the treat-through approach with steroids or vitamin D plus steroids, or even systemic adds-on to control the paradoxical reaction. In the more severe cases, discontinuation of IL-17 inhibitors, and then switch to either anti-IL-23 or JAK1 inhibitors. However, we know that the most reported paradoxical reaction happening with the anti-IL-17 is paradoxical eczema, which we heard before, a generalized atopic dermatitis like eruption that was already reported in this case in phase 3 clinical trial of ixekizumab with an incidence of 12%. So we kind of getting a reasonable number. And there's been a wealth of research, in fact, on the eczema, paradoxical eczema, which the groups from Manchester have actually shown to be caused by can be caused by any class of biologic currently available for psoriasis. The risk is definitely highest with the IL-17 inhibitors, with the adjusted incidence rate per 100,000 of 1.22, and lowest risk with the IL-23 inhibitors. The increasing age, again, female sex, and an history of atopic dermatitis or a fever seems to increase the risk. The typical onset is within 4 months of treatment, and the clinical presentation are once again broad, and they do include classical AD eruptions and facial dermatitis. And again, similar to what I said before, it can persist even after discontinuation of the biologics. Now, what do we know about the pathogenesis? There are some early insights. Here, a genome-wide association study has been performed with 88 cases of paradoxical eczema and 3,000 psoriasis control, and 2 susceptibilities NIP in non-coding regions near UNC5B and CLC1A2 have been identified at genome-wide significant level. What this gene do, as always, is not something very straightforward. The UNC5B is involved in regulating vascular branching in angiogenesis, and the other gene is a transporter involved in glutamate reuptake. So there's more to be studied to identify, to come up with hypotheses here. There's also been a single-cell transcriptomic and immunophenotyping study done on 3 cases, and using psoriasis control and LT controls. And there are some suggestions there that increased type 1 immunity, for example, type 1 interferon gamma and TNF might be at play. However, there is heterogeneity, and it's only 3 cases, so again, to take everything with a pinch of salt. Again, the questions here, is the treatment unmasking a pre-existing susceptibility? Is the treatment enhancing T-cell plasticity with a switch from Th17 to Th2? It's still unclear, but of course we have seen some data now, unpublished data from Michelle today, which seems to suggest this shift is indeed occurring. Now we come to IL-12, IL-23 blockers induce paradoxical psoriasis. This is, of course, ustekinumab-induced PXP. There is a very small fraction of PXP caused by ustekinumab, only a dozen cases reported in literature so far, and mostly they are exacerbation of existing psoriasis. Again, the onset can vary from as early as 2 weeks to 3 years. The female preference is confirmed, and the broader manifestation can be pustular, palmoplantar pustular, classical psoriasis, as well as a change from existing classical to plaque to pustular psoriasis. There are also some isolated reports of pustular psoriasis eruption with the newest IL-23p19 inhibitors, with perhaps an eczematous reaction as well. So again, the clinical phenotype is quite complex. Once again, there is a lack of molecular phenotype, or at least published molecular phenotyping and mechanistic insight. The questions remain: is it a true paradoxical exacerbation or a flare-up? Is there something else that is switching? And the therapeutic intervention are not standardized. Again, in this case, in case of ustekinumab discontinuation, the tendency in the clinic is to switch to anti-TNF. Michelle has already introduced paradoxical psoriasis induced by a blockade of IL-4 and IL-13. This develops in about 3%, or at least that the literature says, of dupilumab-treated patients. It seems to take slightly longer to develop in children and adolescents compared to adults, where it develops within 4 months. There is a risk factor, which seems to be family history, seems to be a risk factor for psoriasis, paradoxical reaction. In most of the cases, it's classic plaque type, and but there are also examples of pustular, scalp, guttate, and inversa. And as Michelle already said, the eruption do not occur in the same areas of AD, so they are really distinct areas that are involved. In terms of pathogenesis, again, we have some early insight from skin transcriptomics. These are 7 cases compared to AD controls and psoriasis control. And indeed, there seems to be a clear Th17 immune shift with increased IL-23, IL-17A and F and AMPs, as well as a signature reminiscent of pustular psoriasis with IL-36 and neutrophil signatures. Again, in terms of the treatment, not standardized, is the same approach, treat-through approach with topical adds-on when it's possible, or dupilumab discontinuation. It's been proposed to switch to tralokinumab, to anti-IL-13, although there are some isolated cases of paradoxical psoriasis also induced by tralokinumab. And then obviously JAK inhibitors, especially JAK1 inhibitors or JAK1/2 inhibitors, upadacitinib and baricitinib. Finally, we come to the JAK-induced paradoxical psoriasis, and there are 5 anecdotal cases in the literature of patients treated with either baricitinib or tofacitinib for rheumatoid arthritis, AD, or juvenile idiopathic arthritis. Onset varies from as early as 3 weeks to as late as 5 years. Obviously, when it's so late, to question whether it's really due to the drug. Clinical manifestations include classical plaque psoriasis, erythematosus, cuttace, palmoplantar pustular. And again, we do have some early insights. This is a study which is done selective skin gene expression analysis, again, from Gillier and Curdin. And there is a partial overlap with the paradoxical psoriasis induced by TNF with the increased type 1 interferon signature that we see here. But there is also an increase in IL-8, IL-6, and IL-17F. So it does look different from the TNF-induced paradoxical psoriasis. And again, in terms of therapeutic intervention, there is dose reduction when feasible, or discontinuation and switching to oral steroids or conventional systemics. So taking all together, what are these potential mechanisms? I mean, we have seen that there is clearly, in the case of the TNF blockers induced paradoxical psoriasis, there is the disruption of a negative feedback loop in the case of PDCs being now unleashed to produce more interferon. which leads to overproduction and disruption of the circuits. There is a shift of polarization of T-cell responses, but this only scratches the surface, and there is way more that needs to be understood. Again, we know very little about genetic factors. Does the microbiota play an effect? Is there an activation of innate immune pathways due to the unspecific FC interaction of those antibodies, and so on and so forth. So I'm sure you will agree there is lots of challenges of differential diagnosis, and for me as a non-clinician, when I start reading psoriasis with eczematous fissures and then I see paradoxical eczema, I wonder, is this the same thing? Are they different? So I think this is important. So the mixed clinical phenotype really calls for a strong, deep clinical phenotyping. Of course, we know nothing or little about unknown risk factors. The pathogenesis is unclear. There's no biomarkers, and there is no standardized treatment. So what are the opportunities? Of course, we need a robust clinical phenotyping, and we need cellular and molecular profiling. As we have seen earlier, we do need to stratify these conditions, these reactions, based on the cellular and molecular profiling in the skin and potentially in the blood. But very importantly, we also need in vitro validation. We need functional study, because it's all well and good phenotyping, both clinically and molecularly, but we also need to validate in vitro what we think is happening there. And so everything together, we stand a chance to resolve the pathogenesis and identify potentially predictive biomarkers. So just a very quick acknowledgement slide for the work I presented. Thank you to my lab and to the clinical colleagues at St. John's for our PXP work, and thank you very much for your attention.